We finally made it to the last section of the course, pediatrics. So let's go through the 3-question warm-up for Pediatrics 1. First question, what's the next step in evaluation of penetrating injuries to the different zones of the neck? Well, zone 1 goes from the clavicle to the cricoid cartilage, and you evaluate an injury there with a 4-vessel CT angiogram and also triple endoscopy of the esophagus, larynx, and bronchi. Zone 2 goes from the cricoid cartilage to the angle of the jaw, the angle of the mandible. You evaluate with surgical exploration just because you can, because Zone 2 is most exposed and the easiest to get to. And then Zone 3 goes from the angle of the jaw to the base of the skull, and you evaluate with the 4-vessel CT angio. Next, what are the cardinal movements of labor? So you have engagement, descent, flexion, internal rotation, extension, external rotation, and finally expulsion. And the last one, an IV drug user has JVD and a holosystolic murmur at the left sternal border. So this is a classic murmur for tricuspid regurg, right? You suspect he's had endocarditis that's destroyed the tricuspid valve. And what's the treatment? You're going to treat empirically for endocarditis with vancomycin. You also need to treat the heart failure, and then ultimately you're going to replace the tricuspid valve. So that's the end of the warm-up. Now let's go to Dr. Seltzer for the lecture.
Welcome to the pediatrics section. Now, if you've been watching these videos in the recommended order, we've already covered a lot of pediatric topics in the various organ systems. Pediatrics is very high yield, so you definitely don't want to gloss over this material. Make sure that you've reviewed those pediatric organ system topics well. But in this last section of the course, we're going to talk about some general pediatrics topics that haven't been covered already. Let's start with physical growth, which is something that we chart on all kids as they come in for regular checkups. First of all, with weight. The initial loss of weight in the first few days after birth is normal, and birth weight is typically regained by 2 weeks of age. If you haven't regained your birth weight by 2 weeks of age, then we start to look for problems. There may not be a problem, but we want to make sure. Birth weight generally doubles by 4 months of age, triples by 12 months of age, and quadruples at about 24 months. From 2 years to adolescence, about 13, the annual weight gain is about 5 pounds a year. Inadequate weight gain can result from poor food intake, including poor feeding and abuse, chronic vomiting and diarrhea, malabsorption, neoplasm, or congenital diseases such as cardiac or endocrine diseases. Weight less than the 2nd percentile on the growth charts or a consistently low weight for a given height suggests failure to thrive. We talked about failure to thrive in the GI section along with the specific criteria. The prevalence of childhood obesity is on the rise in the U.S. It's associated with rapid growth, sleep apnea, hypertension, slipped capital femoral epiphyses, which is where the x-ray shows that scoop of ice cream falling off the cone, precocious puberty, increased incidence of skin infections, social dysfunction, and earlier development of diabetes mellitus type 2. Height, or birth length, is increased by 50% at about 1 year of age, doubles at about 4 years of age, and triples at about 13 years of age. The annual height gain from age 2 to adolescence is about 2 inches per year. So beyond 2 years of age, you will gain about 2 inches a year and about 5 pounds a year. Greater than normal height can be associated with familial tall stature, precocious puberty, gigantism due to excess growth hormone, hyperthyroidism due to excess thyroid hormone, Klinefelter syndrome, Marfan syndrome, or obesity. Lower than normal height can be associated with familial short stature, neglect, Turner syndrome, constitutional growth delay, which is where parents had short stature when they were kids, so this is a normal variant, chronic renal failure, asthma, cystic fibrosis, inflammatory bowel disease, immunologic disease, growth hormone deficiency, hypothyroidism, glucocorticoid excess, skeletal dysplasias, or neoplasm. This is pretty self-explanatory here, and I'm sure you'd be able to pick out a cause of lower than normal height if you were asked that. Head circumference is measured in the first 3 years of life to make sure that the head is not too large or too small. Macrocephaly can be associated with cerebral metabolic disease like Tay-Sachs, maple syrup urine disease, neurocutaneous syndromes like neurofibromatosis and tuberous sclerosis. hydrocephalus, increased intracranial pressure, skeletal dysplasia, acromegaly, or intracranial hemorrhage. Microcephaly can be associated with problems that make the brain grow slowly, such as fetal toxin exposure, like fetal alcohol syndrome, chromosomal trisomies, congenital infection, cranial anatomic abnormalities, metabolic disorders, or neural tube defects. The trend of growth abnormalities helps suggest certain pathologies. A normal growth rate that declines after birth suggests a postnatal onset. Growth that is abnormal from the time of birth suggests prenatal onset, like genetic abnormalities, intrauterine pathology. Growth that is in the low normal range, but eventually becomes closer to the mean, suggests constitutional growth delay. So you're going to be able to obtain that history from the parents, ideally. Growth that is consistently low normal suggests genetic short stature, and you need to compare that with parents' height. Growth should be assessed at each health visit to confirm normal patterns and catch abnormalities early. Labs should be directed towards the disease that you suspect. Treatment for growth problems includes treating the underlying disorder. Also, seek intervention for cases with abuse. Provide parental education to help alleviate poor intake, poor quality diets, or malnutrition, and to help deal with psychosocial issues. Be sure to collect a thorough family history while assessing growth or developmental delays to help distinguish a hereditary cause from an environmental one. So a very thorough family history is particularly important. Next, let's talk about some developmental milestones. It is very likely that you're going to have a question on developmental milestones. You may have 1 or 2 questions. You're not going to have the 3, 4, or 5 that you may have had on step 1, so it's not as high yield as step 1, but it's still worth going over. The highest yield ones are the gross motor and fine motor milestones. At 2 months, these kids will do a social smile, meaning you smile at them and they smile back. For gross motor, they can lift their heads to 45 degrees, and for fine motor, their eyes follow an object to the midline. They aren't talking yet, but they do coo. At 4 months, they will laugh, and they are aware of the caregiver, and they will localize sound. For gross motor, they can now lift their heads to 90 degrees when on their stomach, and for fine motor, their eyes will follow an object past the midline. At 6 months, they know who their parents or caregivers are, and they start to exhibit stranger anxiety. For gross motor, they can roll over, and if you sit them up, they can remain upright without support. For fine motor, they will grasp objects and they'll rake objects to themselves. They'll also attempt to feed themselves, although it's a pretty messy affair at this age. They are also starting to babble at 6 months, mama, dada sort of sounds. At 9 months, they're starting to play interactive games like peekaboo, and they're also beginning to have some separation anxiety, where they don't like for you to drop them off at daycare or leave them with a sitter. For gross motor, they're crawling and pulling themselves up to stand on furniture. For fine motor, they can now get a good grasp on things with their thumbs, and they are starting to say their first words. At 12 months, they are typically beginning to take their first steps and walking with some help. For fine motor, you'll see them use that pincher grasp so they can pick up Cheerios or other finger foods and eat them. And they can pick up anything else that's within reach as well. They can also make a 2-block tower. These different levels of tower building are very classic milestones. As far as speech, at a year they have a vocabulary of about 5 to 10 words. At 18 months, they exhibit what is called parallel play, which means if you put 2 18-month-olds together in a pile of dolls, they may both play independently with the dolls, but they aren't really playing with each other. They're playing in parallel. For gross motor, they can walk well and can walk backwards. They can make a tower of 4 blocks, and they can use a cup and a spoon. At 2 years, they can dress themselves with some help. They can run and climb stairs, 1 step at a time initially. They can build a 6-block tower, and their vocabulary is up to 50 to 75 words, and they speak in 3-word sentences. At 3, they can go up and down stairs pretty well, and they're up to a 9-block tower. They can also draw a crude circle. At 4, they're truly playing with others rather than just that parallel play. They can hop on one foot, and they can draw a line image like a plus sign, and eventually a closed figure like a triangle or a square. Their vocabulary is up to 250 words or more. And at 6, not only do they run, but they skip, and they can draw a stick figure person. Be sure to know these ages for the developmental milestones are only guidelines. It is normal for milestones to occur at an appropriate range of ages, and parents should be reassured that milestones occur within such a range and not at specific concrete ages. Multiple or persistent delays in development can result from things like intellectual disability, genetic disorders like Fragile X or trisomy 21, language disorders or hearing disorders, child abuse, or psychiatric conditions like ADHD or autism. The infantile reflexes naturally disappear by 6 months of age. So 6 months is the number you want to remember for the disappearance of reflexes. If you have any of these reflexes after 6 months, that could be abnormal and could suggest CNS pathology, especially if there is a history of perinatal complications. It's good to know your reflexes. There's the Moro reflex or startle reflex, where extension of the head causes extension and flexion of the limbs. The grasp reflex is where placing the finger in the palm causes grasping. The rooting reflex is where rubbing the cheek causes turning of the face towards the stimulus. The tonic reflex is when the head is turned and the arm on the face side extends and the arm on the opposite side flexes, like this. It's a fencer's position. The placing reflex is where rubbing the dorsum of the foot causes the foot to step up. So if you were to take a 1 or 2 month old and stand them on the ground, you could actually make them walk because of the placing reflex. They can't bear weight, you have to hold them, but they can move their legs in a walking motion because of the placing reflex. So those are the developmental milestones and the reflexes. Let's talk about health maintenance in childhood next. Periodic physician visits are important during childhood to assess growth, detect growth and developmental delays, to provide vaccinations, to screen for certain diseases, and to provide anticipatory guidance. It is important to consider the doctor-parent-child relationship and the ability of the family to understand anticipatory advice when reviewing topics at each visit to ensure the greatest benefit to the child. In other words, for well-educated parents, you might be more technical with your information. For parents who are not well educated or who are going to have a hard time comprehending something, you need to be very simple with your communication to make sure they understand. Some teaching methods that maximize the communication of important information during a visit are repetition, positive reinforcement, limiting the number of topics discussed, and not focusing on minor points. Anticipatory guidance is not as high yield as the rest of this lecture, but there are just a few things that I think are worth highlighting here. From newborn to 1 week, the daily care mentions sleep position and bathing. With sleep position, we're supposed to put them on their back to prevent SIDS, back to bed. And for bathing, the baby does not need to be bathed every day the way many adults bathe daily. If you do, you're just going to dry out the baby's skin. Next, when do you start feeding babies solid foods? You can see that under the 4-month marker. Some will argue that you should push that out to 6 months, but at 4 months you can introduce solid foods. And what is the usual first solid food introduced? Iron-fortified cereal. Pureed fruits and vegetables can be introduced at 4 months of age, but ideally you would wait until 6 months of age to introduce those. When can you introduce cow's milk into the diet? That's at 12 months. What happens if you introduce cow's milk before 12 months? They're more likely to have hemorrhage in their gut, which can lead to iron deficiency anemia, which causes lots of different problems, including loss of IQ. When do kids start seeing the dentist? This is between 2 and 3 years of age. But if kids are at high risk for cavities, then they should go within 6 months of their first tooth eruption. High-risk categories include low socioeconomic status, caregivers with multiple cavities, brushing less than once a day, drinking well water or water without fluoride. At 3 years of age, it mentions a regular sleep schedule and television limitation. What is the recommendation for television on a daily basis for kids? Kids aren't supposed to be exposed to more than 2 hours of media a day, ideally less than 1 hour, and this includes computer time, TV time, and video games. Those are just some of the high yield points to know. Take a look at these and make sure you understand them, but again, this table is not very high yield. So when do you actually see these pediatric patients in the office? If they are discharged from the hospital before 24 hours of age, you really need to follow up within 2 days of discharge. Then we also follow up at 2 weeks, again at 1 month, 2 months, 4 months, and 6 months, because that's when you're going to start doing your vaccines. Then you follow up every 3 months from age 6 months to 18 months, and then visits every year after 2. Let's talk about the vaccine schedule. Again, you don't need to memorize this. If you're going to have a question on it, it's probably only going to be one question. The most frequent question we have seen regarding vaccination schedule is how many of each type of vaccine does the kid get? So how many DTaP vaccines do you give a child? You give them 5. You have 4 Hib vaccines, 4 pneumococcal vaccines, so the total number of vaccines in the series is more important than knowing when you give them. It's easy to remember all of those associated with the 2, 4, and 6 month marker though. There are just a few other highlights I'm going to throw in here. We give hepatitis B at birth. At 11 to 12 years of age, you're supposed to give the Tdap, which is the tetanus, diphtheria, and acellular pertussis, instead of just a tetanus booster. And the meningococcal vaccine is also given at 11 to 12 years of age with a booster at 16. The MCV4 can actually be given after age 2 in kids with asplenia, so that may also be worth knowing. There's also a series of 3 HPV vaccines given to both females and males at age 11 to 12. An annual flu vaccine is recommended for anyone over 6 months of age. One other high-yield preventative thing I wanted to go over is the appropriate use of car seats, which is found in the study guide. Kids under 2 should be in a rear-facing car seat, preferably in the middle of the back seat. You don't put kids in the front seat. Most families use a convertible car seat that can be both rear and forward-facing. When the kid is at least 2 years old and outgrows the weight or height limits for the rear facing in the seat, which is around 35 pounds, then they are switched to forward facing, basically until they outgrow the seat, which is usually around 4 to 6 years of age. Then they're in a booster seat with the seat belt on, still in the back seat until they are 4'9". So it's not an age requirement, it's a size requirement, and that's really the case for all of these. Older children should always use a lap and shoulder seat belt, and all children younger than 13 should be in rear seats of the vehicle. Car seats are definitely high yield for the test. This is definitely fair game for USMLE Step 2. So that's it for this lecture. Go ahead and do the end of session quiz. All right, first question. When do children first exhibit separation anxiety? Around 9 months. And when is gender identity typically formed? Around 2 to 3 years, around the time of potty training. Next, how do you expect weight to increase in the first 2 years of life? By 4 months, weight doubles from the birth weight. By 12 months, it triples, and by 2 years, it quadruples. When can children begin to eat solid foods? 4 to 6 months. And when can children drink cow's milk? At a year. Next, how many total doses of the DTaP vaccine should a 6-year-old have received? 5 doses. And last one, at what age is the meningococcal vaccine indicated? After age 11 and a booster at 16. That's the end of this video. See you next time.